leaders in setting sort of guidelines in relation to podiatry care. And we've got Deirdre Beard. Now she's also a very senior and experienced podiatrist as well, so we're very lucky to have two senior podiatrists who are able to work in this flexible model. We did have a bit of an attrition rate with podiatrists in the first year, and we've actually been to 4 rounds of recruitment, but hopefully we actually will hang on to these two because they're good value. This is Susie Bonney. She's a Wongai woman from Kalgoorlie, and she's bubbly and lovely and fantastic at developing networks and really solid with her case management.
Really good at care coordination.
Yeah. And she's the one who's now doing her graduate certificate in diabetes education as well. This is Michelle Michael, and she's a
blind person.
Yeah, she's our face to the program in Kelmscott. And it is amazing what a difference having an Aboriginal person at the front desk who's actually created a different look around the reception area. It's full of art and photos of different people in the community.
It's really welcoming, all the photos of different events, and you've got the Aboriginal person, our frontline person. It makes a really big difference. And then we go up and greet them and offer them a cuppa, and there's places to sit, there's things for the kids to do, you know, whether it's culturally appropriate art as well that they can colour in.
Yeah, really good. And this is our Doreen. And there's me, the old one at the example. I am, you know, I was asked, I was at a workshop, and we all had to stand in a circle to actually demonstrate how long we've been worked in the paid health sector. And some had been in 2 weeks and whatever, and they went around 30 years, 40. Got to me at the end of the line, and I've been in the health service for 45 years, and I thought, oh my God, this is awful.
That's right, come around to us, Maureen. Been there a long time, so a lot of experience.
Not, I mean, I guess you could say 45 years of wisdom, I suppose. Anyway. But this is the map of South Metro Area Health Service, and this is the map of North Metro Area Health Service. And you can see that South Metro Area Health Service, even though we've got about mirror populations, we're about, as far as size, we're nearly twice as big. And when you look at our most densely populated district for South Metro, it's this Bentley area here. And when we did our mapping, that's when we actually found out that with hospital discharge data, that the majority of admissions for chronic disease from our South Metro Area Health Service were from the Bentley area, and likewise they had the highest incidence of amputation.
A lot of the older generation as well, more elderly people.
Yeah, I think that, yeah, that's true. Yeah. So when we look at our biggest population of Aboriginal people, it's in the Armidale area here. Then Fremantle's actually got the CBD, but then a lot of other shires as well. Rockingham Kwinana is another health district, and Pinjarra, even though it's actually got the smallest Aboriginal population, it's got the biggest tyranny of distance. So we actually had to make sure we addressed, each area actually had a different need, and that's what we've had to accommodate in rolling the services out. So the blue areas are our mobile clinics that we started in 2010.
That's with the van.
With the van, okay. That's at Derwell Yarrigan in Maddington, and at the Otti Centre in South Lake. The yellow is the fixed clinics that we started in 2010, so that's at the Woolwich Court, Kelmscott, and the Canning Division. The pink is the clinics that we've actually started in 2012. That's at Babinga Maya, at Nifro Care in Spearwood, and at Hammy Hill at Boodia. The white dots, when we get to capacity, is where we think we also need to actually roll our service out. But we can't duplicate it. We can't actually, we're running at capacity now. We can't spread ourselves any thinner.
There's only 6 of us.
yeah.
So we're a small team.
Yeah.
And we especially need more Aboriginal male health professionals. Would be good.
Yeah, we're lucky that we can refer to male health professionals in our Aboriginal team for when our men need extra support, because so many of our men have such high needs and they're socially isolated. So we're lucky that we've actually got a bigger Aboriginal team that we can refer to for men's activities and men's events and those sorts of things. And they link into existing men's groups like Mum and Maya.
Yeah, do they come under South Metro, the Aboriginal Health Team, and there's different programs already in place. One of them, which one? The
Mum and Maya
and another different programs, which is really good. We can refer like in-house plus externally, which really works well.
So this is, promotion is actually an ongoing event for us, and this was just some examples of some of the promotional activities. This is at a community event in the Armidale area, where the van actually arrived and we did foot screenings and foot assessments that day.
Can I just say that was Mums and Bubs Day that day?
No, this one wasn't.
That one there?
No, this one wasn't. This was
That one?
No, this was that was another one. You've been to so many, Dora, you don't know which one.
I really thought it was, but the importance is, even though it's a Mums and Bubs Day, you know, they want us there because there's all the different family members there as well.
Yeah, but these are some of our solid Aboriginal elders too that we actually rely on a lot for cultural support. Yeah. This is one of our celebrities. He was an Aboriginal man. He actually is, in his house, 4 generations actually live in one house, Joseph. And when we found him, he actually had, he missed out after an amputation at Fremantle Hospital, and he'd had, you know, the salami amputation starting. And when we found him, he had a severe infection and osteomyelitis, so he had to be actually intensively managed and whatever. But he's fine now, and he's actually got his special boot made, and he's managing his diabetes well, and his family actually see Pop getting better, and he's even taking an interest in, like, he wasn't very good at remembering his medications and things like that. And I must say, a lot of it is because there's so much confusion around medication. For his particular case, because he'd actually had been into hospital, he had medications from a discharge summary that were different to the medications that the GP was holding, that was different when I rang the pharmacist that prescribed it, different to what he prescribed. So there was Joseph with all these tablets, and he didn't have a clue which one he was supposed to be taking. So he's now on a Webster pack that he's managing quite well. So those are the sorts of things that crop up all the time. You'd probably agree with me, Dora, that the medication in the primary healthcare setting for people with chronic disease is a nightmare.
It's like Maureen said, you know, you go into hospital and get another new lot, they're still taking the medication that was prescribed, and then there's so much. Okay, we're running out of time here, but yeah.
So Joseph's one. Good News Stories is a good way of actually promoting, going to community events, and Tourid is our artist, and I think one of our biggest promotions is driving around in the van that people will recognise. Yeah. And this is our day, it's Survival Day, so promoting services is really good. So there's been a variety of different methods to actually promote the service. As you can see, the Noongar Radio, Good News Stories, community events, stakeholder meetings. We've been in newspapers. The artwork and the promotional material we have is culturally appropriate. We've been in newsletters, we've done presentations. Why not? And we've got fantastic Noongar networks as well, which is the way to go, I think. So what have we done so far? We saw 318 new clients in 2011 and 1,500 occasions of service. All of our staff have done cultural awareness training a number of times. At that time, we'd set up 2 of our mobile clinics and 5 of our fixed clinics, and we'd attended 9 community events. we'd developed partnerships with our meet and greets, and Susie had established local networks for our services. In 2012, we actually have already doubled or tripled what we'd achieved by May last year. And already our community events are ramping up as well. We've commenced 3 new sites this year. We're running to full capacity. And just to demonstrate another issue, we had our first prang in the van. Our guys also have to drive the van, fuel it, start the generator, equip it, get it clean, mop it out, restock it. So we're multi-skilling all the time.
Multi-skilled.
So we are working differently. So Doreen, would you like to finish?
Okay. Yeah, we've just gone over time a little bit. Okay, yeah, just a few notes to say that.
That's all.
Okay. We're working towards closing that gap on Aboriginal health. Not duplicating services. We work in the GPs. Yeah, it's a holistic, culturally appropriate service. We're working with partnerships and yeah, making sure how we work is in a culturally secure way to benefit clients and their families. A lot of that we do through yarning. I'll just take a couple of minutes, sorry. The most important thing is the yarning. When we meet someone we don't know, we're yarning with them, you know, we're building up that rapport before. You don't even look at what you have to do, pick up the assessment form. It's sitting down and building that up first. You know, having a yarn, having a cuppa, they'll let you know when they're ready, when they want to move on. So engaging with the community. Really important, like I was saying before, follow-ups on the clients. No 3 strikes and you're out. We don't discharge. We do a lot of advocacy and support, as Maureen's mentioned, and also linking in with other services. Resources always culturally appropriate. What the difference is for us, it's a community. It's a community-owned service. Yeah, we're there for the community, so we have to work in there how they want us to work. It works because this is what Aboriginal people wanted. Like I said before, it was from the ground up. This is what they said they want. Yeah, and it helps having a really good Aboriginal health team working the way we know we should be working, and having all the support of everyone in the Mutitjina team. We all work good together, and also having that support from the Aboriginal Health Team and South Metro Public Health. You know, it all goes together. Yeah, we're all out there to improve or try and close the gap. And I really feel it's a quality service, and yeah, hopefully we'll get the funding to carry on, because there's a lot of people out there. This is what we need. Thank you.
Thank you, ladies. We just wanted to give you both a little present just to thank you for coming today. It was very interesting. Can everyone just give Maureen and Doreen a round of applause? Everyone's welcome to stay for another cup of tea or coffee. On the way out, if you haven't registered, if you just do that as you leave. And we've got a couple of things coming up as well. We've got our Community Safety Awards in July. So if you'd like to nominate someone, there's a nomination form just there. And we've got Community Safety Month in October. And we've got an action kit on the table if you'd like one on your way out as well.
Can I just also mention this pamphlet that you have here? We've actually got the new order where we've got. Have you got the new ones with? Because I'm looking at 8 clinics, but overall with North Metro as well, there's what, 17 I think.
Did anyone have any questions?
I was just wondering if there's anything similar in the West Australian Country Health Area Service or Great Southern Southwest.
I think this is a first. I really do. You know.
I can actually say what's in the wheat belt. I used to be in the wheat belt, and the problems are the same, and the need for the culturally appropriate program is the same, but the model has to be different because it's a lot. You talk about South Metro being large, but Whitlow is much larger, and you have maybe only 10 Aboriginal people living in a town, but they still need to see someone for their feet. So they're working in partnership with Rural Health West, with the coordinated diabetes committee has to go out working with health workers, using local hospitals and doctor surgeries and whatever to provide services, and also with the Northern Diabetes Clinic. And I think Great Southern is doing something similar as well now.
Yeah, I agree that the need is there, but the model would have to be adapted to meet the tyranny of distance in the rural and remote areas.
People just call you if they want to refer.
Yeah, or they can walk in, or a lot of people actually just know that we're going to be in a certain place on a day. Like the clinics that started last year, people know where we're going to be. Like the Monash Jet will be there on Tuesday, and they just rock in. Or you can refer, just a phone call to us is fine. But if you'd actually like some formal referral forms, which gives us a bit more history around the client needs, we prefer it that way as well, because otherwise we have to follow up and find out their medical history. But we have got referral forms, which I'll send to Juliana so that she can send them out to the nurses.
And we do have their pamphlets on the table there if anyone hasn't got them as well.
The referral forms are very simple and easy to fill in, but it helps us with making sure we've got the right name, the date of birth, past medical history, the medications. All those things gives us a thumbs up as far as getting started. Yeah.
We've got a question from Amanda Hudson on our webinar. How is the service funded? And apologies if you've already answered this, they can't hear very well. It's been cutting in and out.
We actually got COAG funding, and that was 1.3 million for 3 years, and similar for North Metro. And that's for everything. That was for buying the van and everything. But it was funded through the Coalition of Other Government, which is a state and federal initiative specifically developed to close the gap. And at the same time, there were 23 other close the gap initiatives that were started to close the gap in Aboriginal health as well. So we were just one of many initiatives funded to close the gap of health for Aboriginal people. But ongoing funding, we hope it actually continues. That will either have to be through core funding, or the federal government actually continues to make these services more sustainable. That's the problem with the COAG funding. It's always for a fixed term, not sustainable funding.
And that's our concern, what's going to happen to everybody if our funding's not continuing. So hopefully.
Thank you. Thanks for coming, everyone, and stay safe on the wet roads as you leave.
Thank you all. Thank you very much.